audience, ladies and gentlemen. In the next few minutes, I would like to show you my 6 months progression. My name is Endre-Botond Gagyi, and I'm a first-year Ph.D. student at the Translational Medicine Center. My supervisor is Endre-Botond, my SMS is Mohamed, and my statistician is Daniel Sándor-Veres. My vision regarding to this topic is that we can reach a state where we can prevent most of the patients from the recurrence and the progression of acute pancreatitis, and my mission is to reduce this recurrence and progression rates. A brief overview of my research topics. The first one is the risk factors of acute pancreatitis progression into recurrent acute pancreatitis and chronic pancreatitis, which will be a systematic review and meta-analysis. Let me briefly introduce its background. The incidence of acute pancreatitis varies globally, affecting from 5 to 80 people per 100,000 and appears to be increasing around the world. Most acute pancreatitis can be completely recovered after standard treatment. However, a proportion of patients eventually develop recurrent acute pancreatitis up to 35% or chronic pancreatitis up to 24%. On the right figure, you can see the sentinel acute pancreatitis event model by Whitcomb et al., which states that acute pancreatitis, recurrent acute pancreatitis, and chronic pancreatitis represents a disease continuum. Data on the risk of developing REP and CP and factors affecting disease progression have been heterogeneous. However, in order to reduce this recurrence and progression rates, it is essential to know all the contributing factors of progression. Therefore, our aim is to comprehensively assess and objectify all the risk factors that can contribute in the progression of acute pancreatitis. We aim to identify risk factors at this stage, specifically focusing on factors that contribute to acute pancreatitis progression rather than risk factors for acute pancreatitis itself. As this study examines the risk factors of acute pancreatitis progression, we use the PO framework for posing the question. The population includes patients with acute pancreatitis or recurrent acute pancreatitis. The exposure involves the presence of a risk factor, the comparison is the absence of a risk factor, and the outcomes are either recurrent acute pancreatitis or chronic pancreatitis. We hypothesize that the presence of a risk factor increases the risk of developing recurrent acute pancreatitis or chronic pancreatitis in these patients. The clinical implication is that if we can identify any modifiable risk factor, we maybe can reduce the recurrence and progression rates in these patients. To achieve our goal, we have done a systematic search in 3 databases using this search key. Here you can see the flowchart of our selection. Out of 23,000 articles, we included 71 in the quantitative synthesis after title, abstract, and full text selection. Now I'm going to show you 5 forest plots, a few of our results, presenting different parameters effect on the recurrence rate of acute pancreatitis. On this first forest plot, we investigated the effect of, the association between male gender, and the risk of recurrent acute pancreatitis. 28 retrospective and prospective cohort studies were included in the analysis. The exposure group consists of male individuals, while the comparison group includes females. The event of interest is the development of recurrent acute pancreatitis. As we anticipated considerable between study heterogeneity, a random effect model was used to pool effect sizes, and for the effect size measure, we used odds ratio with 95% confidence interval. The pooled odds ratio here is 1.45 with low heterogeneity. This result means that male patients have a 45% higher risk of developing recurrent acute pancreatitis compared to female patients. Since the confidence interval does not include 1, this result is statistically significant. This is our second result. Here we investigated the effect of alcoholic etiology on the recurrence rate of acute pancreatitis. 24 retrospective and prospective core studies were included in the analysis. The exposure group here consists patients with alcoholic etiology, while the comparison group includes patients with other etiologies. The event of interest is the same, the development of recurrent acute pancreatitis. The pooled odds ratio here is 1.76, and it is also statistically significant. This result means that patients with alcoholic etiology have a 76% higher risk of developing recurrent acute pancreatitis compared to patients with other etiologies. The heterogeneity is 81%, which means a considerable heterogeneity. this high level of heterogeneity can be explained by a lot of things. These are articles with all sorts of etiologies, but the proportion of etiological composition of the patient is different in each study. The severity is different, there are differences in ages, and there are differences in sex ratio, etc. This is our third result. Here we investigated the effect of smoking on the recurrence rate of acute pancreatitis. 60 and retrospective and prospective cohort studies were included in the analysis. Exposure group consists patients with smoking history. Comparison group consists patients without smoking history. The pooled dose ratio here is 1.45, also statistically significant, and this result means that patients with smoking history have a 45% higher risk of developing REP compared to patients without smoking history. Here we investigated the effect of hypertriglyceridemia on the recurrence rate of acute pancreatitis. 14 retrospective, prospective cohort studies were included. In the exposure group, we included patients with hypertriglyceridemia. The comparison group consists patients without hypertriglyceridemia. The event of interest the same, the development of REP, and here the pooled dose ratio is 2.45. It is also statistically significant, and this result means that patients with hypertriglyceridemia have a more than 2 times higher risk of developing REP compared to patients without hypertriglyceridemia, and the heterogeneity is low here. This is our last result. Here we investigated the effect of diabetes mellitus on the recurrence rate. The event of interest is the same. The exposure group consists of patients with diabetes mellitus, comparison without diabetes mellitus. The pooled dose ratio is 1.49. It is also statistically significant, and this result means that patients with diabetes mellitus have a 49% higher risk of developing REP compared to patients without diabetes mellitus, and the heterogeneity is 0, which increases our confidence in the result. So we have identified 4 modifiable risk factors so far. This is clinically important because by eliminating these risk factors, we may be able to reduce the recurrence and progression rates in these patients. Here you can see the progress of the first project. We finished the data extraction, and now we are doing the risk of bias assessment. Our second project will be also a systematic review and meta-analysis, and also focuses on the progression of acute pancreatitis, or the relationship between acute pancreatitis and chronic pancreatitis. The annual incidence rate of chronic pancreatitis varies between 5 and 12 cases per 100,000 person years. Acute pancreatitis is a severe condition that greatly deteriorates quality of life and reduces life expectancy, and currently there is no specific curative treatment available. A common belief that acute pancreatitis and chronic pancreatitis represents disease continuum, as illustrated by the sentinel acute pancreatitis event model. However, this sentinel acute pancreatitis model is an interesting hypothesis, but implies that all chronic pancreatitis originate from acute pancreatitis. However, there is a considerable number of chronic pancreatitis patients with no history of prior acute pancreatitis episodes. Therefore, our aim is to comprehensively assess the proportion of acute pancreatitis episodes that occur before the development of chronic pancreatitis. This will provide a more comprehensive understanding of the relationship between acute pancreatitis and chronic pancreatitis, and help refine the existing models of disease progression. This will be a proportion meta-analysis, so we use the PICO and the COCOPO framework for posing the question. Our clinical question is, what is the proportion of AP before CP? And we have so far 6 key articles, and the topic is feasible. So a brief summary of my topics. I would like to finish the first one by the end of June, and the second one by the end of August. And thank you for your attention.
Congratulations. In your first project, we have seen that many risk factors are responsible for the chronic acute pancreatitis. Do you have data on how additive they are? What happens if somebody has 2 or 3 or 4 of them?
Yeah, we investigated separately so far.
Mm-hmm. Do you know any
currently
data in the literature from that?
Yes. Well, I suppose if you have more the risk factors, you have more the chance to have a recurrent. But
yes, it sounds logical. But do you know any data, or have you read something?
No.
Okay, thanks.
Have you found any risk factors that you would expected to increase the risk of progression, and then it was proving otherwise? So have you found like a disease that you thought it would, increase the risk, and then in meta-analysis not?
Yes, we found that interestingly, hypertension appears as a protective factor against recurrent acute pancreatitis. Which was
Why is that? How would you explain that result?
Okay, we're still working on it. That's why I didn't show.
Maybe because of the medication that's used in hypertension, or statins, or I don't know.
He clearly asked his mentor, but he wasn't able to answer this question for him.
If I can make a comment, I mean, we just do another study actually on children that they got some orofacial cleft, and then all the studies are investigating one single factor, like alcohol, or like smoking, or like, I don't know, diabetes. But virtually, I mean, out of the many studies, there was only one which actually was interested or clearly described some interactions. I mean, investigated whether alcohol and diabetes, alcohol and smoking, and so this could be a factor actually, I mean, depending on the country, which might cause a big difference. Or when we talk about alcohol, I mean, alcohol consumption is different if you talk about Russia or you talk about, maybe not Hungary, but to, I don't know which country. I mean, so there could be quite big differences. So therefore the effect actually could be quite different. But I don't know, I'm just speculating, and this is our problem too. I mean, I think we all see this kind of heterogeneity that we do not know or try to understand.
Thank you for your comment.